Love Boise State Public Radio podcasts? They are free to enjoy, but not free to produce. If you can give, your support helps keep shows like Idaho Matters and Scandalize available to everyone. Donate now at boisestatepublicradio.org.
From the studios of Boise State Public Radio News, I'm Gemma Caudette. This is Idaho Matters. A major change for some Medicare recipients. Starting today, millions of seniors may be eligible for lower-cost weight loss drugs through a new federal pilot program. Supporters say it could improve health and quality of life for people living with obesity, while others are raising questions about who qualifies, what it could cost, and what it means for the future of Medicare. It's Wednesday, which means it's time for our Doctor Roundtable with Dr. David Pate, former CEO of St. Luke's Health System and the co-author of the book, Preparing for the Next Global Outbreak. Hi, Dr. Pate.
Hi, Gemma.
And folks, remember, if you have a public health question, send us an email, idahomatters@boisestate.edu. So, Dr. Pate, can you first walk us through what this new Medicare Bridge program is and who actually qualifies for these medications on this program?
This is a trial period. I think it's a really good thing. It will go through the end of next year. And it is basically designed to look at, is the cost of the Medicare coverage for these drugs, is it worth it in terms of the improvements in health? And I think it might very well be, because if we can make the seniors healthier, bring their diabetes under control their weight, do you see less hospital admissions? Do you see less expensive chronic diseases? And so I think that's a really good thing to do. Now, it is very complicated, and as to who is eligible and who is not. And it's even a little bit confusing the way they've set this up, because first of all, to be eligible, you have to have a Part D drug coverage program. The Medicare does not ordinarily cover outpatient drugs. And so the typical parts of Medicare are A, which is for hospital coverage, and B, which is for outpatient and physician coverage, and so forth. There's a Part D, as in David, that you have to have that. But on the flip side, if you're already getting coverage for a GLP-1 through Part D, then you're not eligible. So that's kind of I was surprised to see that. What it would mean is, if you're eligible, you would just pay essentially a $50 copay per month for the drug, which is a big savings. But you also have to meet specific criteria. Your BMI, the weight index, has to be over 35, or if it's 30 to 35, then you have to have also uncontrolled blood pressure or be a pre-diabetic. Or you have to have evidence of peripheral vascular disease or chronic kidney disease. Or if you're in the BMI category 27 to 30, you have to have prediabetes, a prior heart attack, prior stroke, blocked arteries, et cetera. So it's going to be complicated, and doctors are going to have to sort through this. But you all also are not eligible if you already have type 2 diabetes, and if you have moderate or severe sleep apnea, and that's going to be problematic, because that's probably going to eliminate quite a few people, or if you have fatty liver disease. So it is going to be complicated, but it's a good thing for Medicare to be doing this trial.
So, Dr. Pate, obesity has increasingly been recognized as a chronic disease, right, rather than just a lifestyle issue. How significant is it then that even with all of these restrictions, that Medicare is testing coverage for weight loss medications?
Well, I think it's good because, and unfortunately, when the law was put in place, it was, I think, before there was as much consensus as there is today of exactly the point that you made, that obesity is a disease, not just poor self-control. Actually, there's language in the Medicare statute itself that Medicare cannot pay for weight loss drugs. I think that the benefit of doing this study is that if you can, at the end of it, make the financial case, look, we spent, and I'm just going to make up absurd numbers to make the point, we spent $1 million on providing GLP drugs for our Medicare beneficiaries, but we saved $3 million in hospital costs, dialysis costs, or other costs and so forth associated. Then I think you can go to Congress with that and look to see if we can change the statute.
So these drugs, Dr. Pate, have also, I mean, of course, shown benefits with weight loss, but they've also shown benefits that go way beyond weight loss. I mean, we're talking things like reducing the risk of heart disease, right? I mean, improving other health conditions. So I'm curious from a medical standpoint, how much of a difference could this expanded access, make?
I really think it could be huge. And you, frankly, and I've mentioned this on your show before, I have never seen this in my entire career where a drug was approved for some specific benefits, but then once it was out, we found so many other conditions that it improves. This is really extraordinary. But in addition to things that you've mentioned, first of all, there's a study showing that people that are on these drugs, they have less severe COVID. That could add up in savings. You and I have talked on the show before about the growing understanding that some dementias and neurodegenerative conditions may be related to inflammation. Well, these drugs decrease inflammation. So will we see benefits there? I think we have only begun to scratch the surface here. And doing studies like this could really expand our knowledge as well as expand the coverage. And then when you do that, I suspect we're going to even learn some more benefits as we can follow people on these medications for a longer period of time.
And as we mentioned, I mean, this is a pilot program, and you laid out the pretty strict eligibility rules for it, Dr. Pate. Are there any questions or concerns that you think might be issues like in practice rather? And what should Medicare recipients, I guess, what should they be asking before they just make the assumption that they're going to be eligible?
Yeah, well, one of the things that I worry about, and I've mentioned before on your show about these drugs, because there's no miracle drug for anything. But while this drug is very good, on the other hand, you do worry about people that would look to this drug as the whole solution. And by that, what I mean is, what we really need is people to adopt healthy lifestyles. I see the use of the GLP as it can help people move in that direction because, frankly, it's very discouraging to engage in all these efforts if you don't see results. But with the GLP-1 drugs, most people do see results. And so what's important is that we not just give this medication, or people don't just expect, okay, doc, give me the medication and then everything will be good. Because you still need to adjust your diet. You need to engage in exercise. And one of the particular risks is that with these drugs, yes, most people will lose weight, but if you're not exercising, you will lose muscle. And then you could have a really bad problem in terms of the fact that this is an older population that for many reasons may be at increased risk for falls and all. We certainly don't want to make their strength deteriorate. And so it needs to be medically supervised. The doctor needs to make sure not only that the patient meets the criteria for this, but that the patient is motivated to engage in other efforts to make this part of a lifestyle change, not the sole basis for a treatment.
Hey, Dr. Payton, what could this mean in the future for people who are not on Medicare in regards to a lot of times, right now this drug is not covered by a lot of insurance companies. And so people are having to pay out of pocket. And there seems to be sometimes a process where if we see Medicaid starting to cover something, eventually we then see, private insurance companies start to cover this. Can we make that correlation yet or not?
Oh, I think we can, because I think you're exactly right. For example, all of those Part D plans, which are run by private insurance companies, if Medicare makes a coverage decision, they're bound to that. So that would expand access immediately. But also, just as you said, many health plans do use the Medicare coverage decisions as the basis, or at least an important part of the basis for their own coverage. And as far as what I think about, one of the things that I'm very concerned about is the growing rates of childhood obesity that we're dealing with. And I'm worried about children who are set up for very serious problems that normally, years in my generation, we didn't see until people were at the end of their careers or into retirement, that we might be seeing these midlife now as these children age. And so I think a very important part of this is, as we get more experience with this, have more positive results, that we have our government look at funding studies to assess the benefits and the risks of these medications in pediatric populations, to see if this might be a way for us to deal with this growing childhood obesity problem that not only will impact future healthcare costs, but impacts things like the percentage of our populations as eligible to serve in the military and other kinds of things. So it could be quite important.
There's new guidance from the federal government, Dr. Pate, that could make testosterone replacement therapy easier to access for some men. This is after a review found that the treatment might be safer than, I guess, previously thought. How do these proposed testosterone label changes actually impact how you decide whether to prescribe testosterone therapy in practice?
Well, it will be a major impact, Gemma. Just as we talked, I think it was last year, when the estrogen guidelines got revised for women, because we found out that a lot of the things that we were reasonably concerned about just didn't pan out in the studies. And the same thing has happened here, that we've had a lot of concerns based on the way that we know testosterone functions, that it might, we were concerned. Yes, there are men who develop low testosterone. They have primary organ failure and don't produce the testosterone and can have symptoms. But on the other hand, concern are we putting these people at higher risk for heart attacks, for strokes, for blood clots, for prostate cancer, those kind of things. And what the study showed is that most of those concerns did.
You're coming in and out again, Dr. Pate.
Oh,
yep, we've got
darn
you.
It. So sorry.
Nope, we've got you now. No, it's okay. Live radio.
But that there are, it's not for everybody. And so certainly somebody that has metastatic prostate cancer, we wouldn't talk about using this for President Biden, for example, or anybody else that had that. People have very significant prostate enlargement. That needs to be a careful decision with the doctor. If you've had a history of blood clots or pulmonary emboli, that needs to be considered. So there are still some people that probably shouldn't take this, or at least ought to have it carefully weighed, the risks and balances with their physicians. But those men that have demonstrably low testosterone levels and have symptoms, loss of interest in sex, problems with erectile dysfunction, problems with energy, those kinds of things. Now they can have a conversation with their doctor. And I think the doctors are going to have a lot less worries about using this when indicated. Now, I want to stress this does not mean that you should go out on the internet and go to these supplement sites and order some testosterone. That is all perfectly safe. That I cannot assure you of that, and especially in your own situation. So talk to your doctor.
So, Dr. Payne, I want to talk a little bit more now with our couple minutes that we have left about this growing Ebola outbreak in Central Africa, because the U.S. is now sending an experimental treatment into clinical trials. And this is an experimental antibody treatment that hasn't been approved. So what do we know about this drug, and why is it important to study it in the middle of this outbreak?
Well, frankly, we never want to have an outbreak like this, but outbreaks do give you a great opportunity to test things that you think might work because you've got plenty of cases. And while this is bad that it's such a large outbreak, the good news helps you get to an answer much quicker because, first of all, this current outbreak is killing about a quarter of the people who get infected. So that's a very dramatic outcome you can look at to see if you can impact. And as I said, there's plenty of people getting infected. So they're going to study this drug, but we have two antiviral candidates. I'm very excited that there is some initial information showing that maybe remdesivir may be helpful, and people may think that sounds familiar, and that's because that's a antiviral that we used for COVID in the hospital. And I would not have guessed it would work for this, but there is some basis for thinking that. And then there's another antiviral that may be able to be used as a preventative when there are close contacts with infections, which would be hugely helpful. And that's going to be involved in some trials. And some of these trials are getting underway this month, which is going to be great. We need to learn more about this disease. And this is an unusual form of Ebola. So this is a really good time to do this.
And why does that matter so much, Dr. Pate? Because it's a different strain when it comes to developing vaccines and treatments. And I've got about 2 minutes with you.
Yeah. So every time we do these kinds of studies, we learn more. Even if the study doesn't pan out, let's say one or two of these drugs doesn't work, we will learn because part of the study is looking at the immune response, looking at the host factors, and the more we learn from these, the more that we may be able to apply to even other infections and potential future threats. So there's really a lot of value in doing this. Obviously, what we hope to do is save lives in this terrible outbreak that we're dealing right now. But as we've talked about, we are a global society now, and we are often one airplane ride away from somebody introducing a novel virus into the United States. So it's in everybody's interest that we learn what we can.
All right. Well, as always, Dr. Pate, we so appreciate you and your expertise. We've been speaking with Dr. David Pate. He is the former CEO of St. Luke's Health System, as well as the co-author of the book, Preparing for the Next Global Outbreak. And remember, if you have a public health question for Dr. Pate and you'd like him to answer it, it's super easy. Just send us an email, idahomatters@boisestate.edu, and we will do our best to get those questions answered live on the air for you. And that'll do it for this episode of Idaho Matters. Make sure you check out our podcast feed because you can find more episodes of topics that might be interesting to you. And for more local news and headlines, make sure you subscribe to the Connector podcast. And if this episode meant something to you, text it to a friend.
Each story you hear on Planet Money starts with a question. What happens if we refund tariffs? Why are groceries so expensive? At NPR, we stand for your right to be curious, because the forces shaping our world can be hard to see. Follow NPR's Planet Money wherever you get your podcasts and start seeing how the economy really works.